Hello to all my budding dentists. Hope you all are doing well, going with your academics, and hope you all are focusing on your studies. So, in this video, we are going to discuss red and white lesions of oral cavity, and probably it will take 2 or 3 lectures to cover this topic because all you know that this topic is quite lengthy, and we'll not go through all each and every topic. We'll just go through like some of the important topics or some of the important like lesions like leukoplakia, erythroplakia, which are important as like in exam point of view. So you all know that the oral mucosa, if you see the oral mucosa, the normal mucosa is translucent or pink in color. The normal mucosa is translucent or pink in color because of the underlying connective tissue. Because the underlying connective tissue appears red, and because of that it appears pink outside. Now, but still the normal mucosa color, either it will be red or white, depends on the degree of keratinization. If the keratinization increases, it will appear white. If the keratinization decreases, it will appear red. Okay, now the classification for your exam, like the question can come as classify the red and white lesion and describe the oral submucous fibrosis or erythroplakia, leukoplakia, like this question can come. So you need to remember the classification very well. So we have like just written the separate white and red lesion. So the white lesion could be like fordyces granule, leukoedema, linea alba, lichenoid reaction, and hairy leukoplakia. PVL is that your proliferative verrucous leukoplakia, your oral submucous fibrosis, verrucous leukoplakia, carcinoma, sorry, and hairy leukoplakia. Then the red lesion are hemangioma, pyogenic granuloma, homogeneous erythroplakia, pemphigus, pemphigoid, and median rhomboid glossitis. We are like going to discuss only like few important topics like erythroplakia, leukoplakia, which can come in your exam. So we are going to discuss that only. Then we have like one more here, like your erythroplakia. Just writing it down here. Okay, so first we are going to see our leukoplakia. So what is leukoplakia? So leukoplakia is your pre-malignant lesion. It is a pre-malignant lesion. Leukoplakia is pre-malignant lesion. So how we define our leukoplakia? So leukoplakia is basically nothing but a white patch or a plaque like lesion that appears on oral mucosa with any chemical or physical causative agent except use of tobacco. So it will have like appearance like white or a patch, which is like clinically it will appear or whitish, and if we go for like biopsy and all that, we can also assume that it is a leukoplakia. So we'll see first the etiology. So the first thing we are going to see is the etiology of leukoplakia. What could be the etiology? So the etiology could be सबसे पहले like the main etiology. If you see the main ones, like this is not working, so the main one, if you see the main, so the main one are tobacco and alcohol. These are the two main etiology. Then if we see other associated lesion, like other associated infective factors, so it can be candida causing leukoplakia. It can be your oncogenic hepatitis V types, and it can also be your treponema pallidum infection. treponema, palladium infections. Then if you see genetic factors, the genetic factors which are associated with leukoplakia or which can cause leukoplakia are bloom disease. Like, you just need to like see the name of disease, it is not that important, but you will just like need to know. Fanconi anemia and dyskeratosis congenita. Okay, so now for now you need to just go through the classification part. Now, what is the classification of leukoplakia? So we'll just simply see the classification of leukoplakia. It is your homogeneous type, which will appear either like completely white. Then you have heterogeneous, which will be mixed red as well as white. Then you have your speckled, you can say speckled or like non-homogeneous and all that. Then we consider PVL also, but PVL is nothing, so we are just like giving her like the name here also, PVL, which is your proliferative verrucous leukoplakia. So first, if we see homogeneous, so homogeneous is nothing but these are like raised white plaque, raised white plaque. And like combinedly we are going with clinical features. So these are nothing but the raised white plaque. The appearance will be smooth to leathery texture, smooth to leathery texture. And then heterogeneous, it will be mixed, like red plus white appearance, it will be mixed. Now speckled one are like small plus hyperkeratotic nodules, like there will be erythematous base, erythematous base, and over this, like over the erythematous base, there will be hyperkeratotic nodules. Hope you all are getting it well. Then PVL, which is important, PVL, which is your proliferative verrucous leukoplakia. This one is like your more aggressive one. So this is the most aggressive type. This is the most aggressive type. Then this is like this is morely concerned or like associated with your papilloma virus, which is HPV. And it is basically, if you see the site of this, the common site of this will be lower gingiva, and as well this is mostly seen in female. Okay, now we have seen this. Now we'll see clinical feature, like some clinical feature which are like all over, like this is going to be for all over leukoplakia. So clinical features of leukoplakia. which are like, you can just write the clinical features of leukoplakia, the normal general ones like age, then sex, then site, and then you can write all these, like just write this before and then you can write the normal ones. So age will be like middle age, middle to old age, which is like fourth to seventh decade of life. Then if you see, it is most commonly seen in males, then females. Then site will be your buccal mucosa, then your palate, then your alveolar ridge, then your lips and tongue. So these are your site where you can see the leukoplakia. So if you're working in the clinics and if you can see like there can be suspect of leukoplakia, just go with the history. And if you see, like you will first see the most commonly you will see it on buccal mucosa. Just take the probe and retract it and you can see the white bands or like patches on the buccal mucosa. And after seeing that, you can just see the case history, like go with the history, ask the patient about the history of tobacco and alcohol. Now we'll just see the differential diagnosis of leukoplakia also. Differential diagnosis. The differential diagnosis could be your leukoedema, frictional keratosis, your pseudomembranous candidiasis, and many more. So we will just see the investigation and treatment of leukoplakia. But before that, I want to like just add a note over here about leukoplakia, that the most common side or like the high potential malignancy side are like higher potential for malignancy, sites are basically your floor of mouth, and your ventral surface of tongue. Why it is, the reason is simple, because the epithelium is thin here, because your epithelium is thin here. So there will be there will be vascularity, but it will be easy to spread, and it is a non-keratinized site. If you remember the pathology or the first year histology part, it is a non-keratinized site. So there are like two reasoning for this, why these two sites have high potential for malignancy. Now we'll just see the last part, which is your treatment. So treatment of leukoplakia. So we can just cover it in short, but I'm just explaining it like more because it is going to be like your second year, third year and final year subject. So just stay with me. You can just make it short by your own after just going through this video. So leukoplakia. So if any patient suspect of leukoplakia, you think the patient is suspect of leukoplakia, so first you have to comfort the patient, maintain his diet, like tell him to quit the habit and all that, counsel the patient completely. So these are the like basic, go with the basics first. Now if we go with the pharmacological medication, so just go with topical antifungal agents, which are your like candid cream. You have your candid cream and your clotrimazole. And how you gonna subscribe it patient? Just to apply this over the lesion thrice a day, and this is going to be like for a week. You can just keep the patient doing it for a week. Now if after a week when the patient come to you, so there could be a good response or there could be no response. So there could be no response to the medication, and there could be reduction in size. You can see the lesion has reduced to its size. So if the lesion has reduced to the size, you will tell the patient to continue this until it will like completely gone, and continue with the antifungal agent for 1 month. You will tell the patient to continue this for 1 month. And if there is no response, and after no response the size of the lesion is like less than 1 centimeter, the other condition could be it should be like more or equal to 1 centimeter. So if the size is less than 1 centimeter, we'll do incisional biopsy. And if the size is more than 1 centimeter or equal to, we will do excisional biopsy. If the size is less, we'll do excisional. We'll completely take out the lesion because the lesion is already small, so we'll do the excisional biopsy. And if the lesion is more than 1 centimeter or the size is equal to 1 centimeter, we'll do incisional biopsy. Now in incisional biopsy, you can see that there are again two conditions. The dysplasia could be there, the dysplasia could be present, or dysplasia could be absent. So if the dysplasia is present, we'll just do two things: total excision of lesion with graft, or we'll tell the patient to for the follow-up once in 6 months, and this would be for like 3 years. And if excision is not possible, like if somehow the excision is not possible, we'll go with the medication. We'll tell the patient for capsules of lycopene 4 mg BID or 8 mg ORI for 3 months. We can tell this to patient, or we can tell for capsules of antioxidant. We'll tell the patient take the capsule of antioxidants with your selenium BID, and this would be for 6 months. So we can tell the patient to do this, as well as topically we can tell patient to take bleomycin 1% thrice a day, and this is going to be for 15 days. And this is like, just see, if the size is less than 1 centimeter, we'll do the excisional. If more, then we'll do incisional may there will be chances of the presence of dysplasia and the absence of dysplasia. If the dysplasia is present, we'll just do the total excision. If it is absent, we'll just go with the medication. Okay, simple it is. And if the dysplasia is absent, we'll just go with retinol only. We'll tell the patient to take retinol A, which is going to be your like vitamin A and log, and the ointment application, and this ointment application would be like BID for 1 month. Now just take the small like quick revision, or we'll just do a summary of all the topic, like just 5 minutes we'll go through all everything, like we'll just go from the start. So what we have seen, the red and white lesion, the normal mucosa is translucent pink in color. Because of the underlying connective tissue, it could be white or it could be red. The degree of keratinization will determine the color of the mucosa. If it is increases, it will appear white. If it decreases, it will appear red. The classification, you just go through it, and then we'll just jump into the leukoplakia. What it is a pre-malignant lesion, white plaque patch which appear on the oral mucosa with any chemical or physical causative agent. And if it is quite confusing for you to read it, like with the except use of tobacco, just remove this part, okay. Now the etiology will be like tobacco or alcohol, and the other will be like your candida causing leukoplakia, your oncogenic HPV types, your trypanosoma pallidum infection. The genetic factors are also involved, like Doom disease, fanconi and dyskeratosis congenita. The classification, before the classification, just go through the like normal clinical feature, which are like age. It is seen in like middle to old age, like fifth or fourth or seventh decade of life. And then if you see the sex, so it is mostly commonly seen in male other than female, because of the habit, because the habit is more in male, that's why it is seen more in male. The site would be your buccal mucosa, palate, alveolar ridges, lips and tongue. Then your classification, they would be like homogeneous, heterogeneous and speckle. There will be homogeneous, heterogeneous and speckle. And your PVL, so homogeneous mate will appear like smooth leathery. In heterogeneous, it will appear like mixed red plus white. And speckle mate, it will be small, plus it will have like your hyperkeratotic nodules with the like over the erythematous base. Then PVL is your proliferative verrucous leukoplakia, which is the most aggressive type, and the papilloma virus is the most like common factor involved with it. The site your will be for PVL would be like lower gingiva, and it is most commonly seen in female. Then your differential diagnosis for leukoplakia will be leukoedema, frictional keratosis and pseudomembrane candidiasis. And I have just told you that the highest potential for malignancy would be like on floor of the mouth or ventral trunk. Why? Because the epithelium is thin here and it is non-keratinized. Then the treatment, if we see, the treatment is like normal. Go with the basic first, tell the patient to calm down and explain him, like counsel him, tell the patient to quit the habit. Then the topical, you will prescribe the patient topical antifungal agent, all the topical antifungal agent. And you will go with the candid cream like clotrimazole thrice a day for 1 week. And if there's like good response, the size has reduced, continue this habit for 1 month. If there is no response, and if the size is like less than 1 centimeter, excise the lesion, we will go with the excisional biopsy. If the lesion is more than 1 centimeter or equal to 1 centimeter, we will do incisional biopsy. In incisional biopsy, there could be presence of dysplasia or absence of dysplasia. If there is presence of dysplasia, there could be two things, like you will do the total excision, or either you will, if the excision is not possible, you will go with the medication. And if the dysplasia is absent, you will go with the ointment, which is retinol, vitamin E analog. We will do it BID for 1 month. And this is the short video. And I guess it is not short now, but still I have tried my best. And these are like I have completed like for your exam point of view, and you can just skip so like 2-3 points if you're writing this on your exam. Like it is going to be like for your 3 marker and 4 marker. And hope and next video we are going to cover the erythroplakia. We'll see, because this is also like very important topic of yours. So the next video topic will be your, I hope you all will just see leukoplakia once, because leukoplakia is quite connected to erythroplakia. So it is going to be your homework to see leukoplakia once before the next video. And hope you all will just go through it once and subscribe to the channel, like the video, share this video to your friends, to your batchmates, help your batchmates too. And be with me, like the video and click the bell icon also to get the notification. Thank you so much.